Hi, welcome everyone. This is the session on lung carcinoma. I'm Ben Greenspan.
And I'm Samuel Langieri.
Very good. And first of all, I want to remind everyone to turn their mobile phones to silent or vibrate. Also check the WFNB app for latest information. There were some changes, but didn't affect this session. And to receive CME points, you have to confirm your participation in each session. You probably all know how to do that. I'm not sure I do. I don't know if I get credits anyway. Okay, so the first speaker is Dr. Tom John, who's going to give a presentation on management of non-small cell lung cancer in the age of immunotherapy.
Fantastic. Thank you very much for the introduction. So my name's Tom John. I'm a medical oncologist, otherwise known as the clinical guy. Okay, so we'll go back. There we go. So I'm a medical oncologist at the Austin Hospital here in Melbourne, and a translational researcher. So my initial brief was just to talk about the etiology and management of lung cancer, and then I read the actual title that was given to me, and it was a little bit different: management of lung cancer in the age of immunotherapy. So I went back and I've put in a lot more about immunotherapy. So hopefully it's not too difficult to follow. But I think we do need to go back and actually go back through a little bit of history. This is just a brief history of the world. You know, dinosaurs go extinct. There's a whole lot of wars, and then unprecedented technological advancements, and then videos of cats. And it does seem to be that when these videos of cats came about, this is when immunotherapy was spawned. But this is actually the real history of immunotherapy. And we go back to the 1890s when William Coley had this theory based on some patients getting septic of his with sarcoma and then having complete remissions. And he developed this series of toxins and hoped that by triggering the immune system, we could then treat cancer. And that was at around the turn of the century, and there was a long period of time there where there was a lot of hope, but not actually much happened. And then in the 90s, there was a lot of skepticism. And in fact, whenever we saw an immunotherapy trial, we sort of rolled our eyes and thought, well, not much is going to come of that. The immune checkpoints were actually discovered in the 90s. And so it's, even from when they were discovered and published, there's been another 20 years before that has come to be anything. And now we're in this age in 2010 really, where the first immunotherapy drugs have been approved. So this is a very young field. We've only been using these drugs really in the last 5 to 10 years. We are learning literally by the day. So just some background to lung cancer itself. I know this is not new for most of you, but the key cause of lung cancer worldwide does still remain smoking, and you can see that there with the largest piece of that circle. But there are other causes such as asbestos. Passive smoking is still a recognised cause of lung cancer. A non-smoking spouse has a 20% increased risk of developing lung cancer. And the reason why I'm in this field and why I think this is important is because lung cancer remains the biggest cancer killer. So even though it's not the commonest cancer, it still remains the biggest killer. In Australia, we generally quote that every hour someone dies of lung cancer, and worldwide you can see it ranks as one of the biggest killers. And in fact, even in non-smokers who develop lung cancer, it's a major killer. Worldwide, lung cancer, as I said, is the biggest killer. But you can see demographically it tracks really with smoking, and in countries where smoking was taken up quite aggressively, the rates of lung cancer are the highest. And of big concern really is in China here, where you can see the rates of lung cancer have probably they haven't peaked yet, because half of the male population actually smokes. North America is another major centre for lung cancer, and as well as Europe, particularly Eastern Europe. So I'm going to try and bore you a little bit with some biology because I think this is also important in how we go on to treat lung cancer. We are becoming a lot more aware more recently of some of the molecular drivers of lung cancer as well as the cells of origin. So this very nice review that was published last year by Charlie Swanton really shows that there are 3 or 4 major subtypes of lung cancer, and they arise in different parts of the lung itself. So adenocarcinomas tend to arise more in the alveoli. They tend to be switched on predominantly by EGFR and RAS pathway activation. So that can be either through mutations or through copy number alterations. Small cell lung cancers tend to arise more proximally from the neuroendocrine cells, and these tend to have losses in P53 and retinoblastoma protein. So they're the predominant drivers, and these different driving mechanisms actually alter the response to therapy, which is why I'm sort of briefly touching on this. And lastly, squamous cell carcinomas, you can see they tend to arise even more proximally in the bronchus. And the pathways that switch squamous cell carcinomas on are very different to those that switch adenocarcinomas and small cell. And part of that explains why they look so different histologically under the microscope. Again, just talking a bit more about biology, and I'll come back to this just as we're sort of understanding the biology of the disease. It is becoming more apparent that while you have an initial event which triggers a carcinoma, with time, and this is sort of, again, passing on through time, you can see you have one sort of major clonal event, but then several subclonal events. And it's these subclonal events that probably drive metastases as well as resistance to therapy. And what we're starting to understand now is that these subclonal events can actually be driven by things such as chemotherapy itself. So we could be driving a tumour from a more clonal cell into multiple subclones. And this may become important in the age of immunotherapy. In tobacco-related lung cancer, there are multiple different mutations. So you can have a clonal event which occurs from multiple hits. We know in most adenocarcinomas, there's usually, from smokers, there's usually about 10 mutations per megabase. And this sort of comes into play when you start thinking about immunotherapy and response to immunotherapy. And so this, again, is another way of describing the clonal evolution of lung cancer. And what I've got here is we've basically plotted different tumour types. And you probably may have appreciated here already that melanoma, which is probably the tumour type that responds the best to immunotherapy, has multiple mutations. So that's the trunk here of the tree, which tells you the number of mutations, and very few sort of subclonal spin-offs. And these are the tumours that are most likely to respond to immunotherapy, whereas you can see there are other tumour types. Breast cancer is a classic where there are not that many mutations and also not that many subclonal events, and it does not tend to respond to immunotherapy, whereas adenocarcinoma of the lung does actually tend to fit in between there, where there are multiple mutations. There's, as I said, often more than 10 non-synonymous mutations per megabase, and there aren't too many subclonal events. So they're the tumours that tend to respond the best. We know that lung cancer survival is driven by stage, and I don't think I really need to harp on about this, but this is why staging is so important, that based on, and staging also drives how we manage the disease. You can see there the 5-year survival for a patient with stage 4 disease is quite dismal, but also the 5-year survival for someone with even local disease is not particularly good either, particularly if you compare that to something like breast cancer. So treatment, as I said, is largely dependent on stage, and it's very hard to show this pictorially, but these are the standard sort of therapies. This is how we generally tend to manage lung cancer today. So stage 1 to stage 2B, the treatment is generally surgery with or without adjuvant chemotherapy. The chemotherapy you use doesn't really matter as long as it's a platinum doublet agent. There have been several trials now that have shown that no doublet is more superior than another. The toxicities can be slightly different. We also treat tumours. So if they're a node positive, we will recommend adjuvant chemotherapy. If the tumour is greater than 4 centimetres, based on subgroup analyses from several different trials, we will offer adjuvant chemotherapy. And the absolute benefit to adding chemotherapy across the board is around 5%. So it's not fantastic, but it certainly adds to the rate of cure. And there are several trials now that are looking at adding immunotherapy to this mix. So BR31 and Pearl are 2 international trials that add immunotherapy after patients have had surgery, adjuvant chemotherapy. And it'll be interesting to know whether this makes a difference. We already know for stage 3A non-small cell lung cancer, where chemoradiation is the standard of care, that adding a drug called durvalumab, which is a PD-L1 inhibitor, increases the rate of cure. The hazard ratio is incredibly strong at 0.5, and so this has now been adopted as the standard of care. The name of that trial was called Pacific. It was published in the New England Journal of Medicine last year. And stage 4 lung cancer is managed predominantly based on the molecular status of the tumour as well as PD-L1. So where we come to the nuclear med physicians is really often staging is our biggest need, but the next thing that we're really interested in is what's the best site that we can get the most amount of tissue from, because we're interested in much more than just knowing if it's an adenocarcinoma or a squamous cell carcinoma. We're interested in some of the molecular drivers as well as whether it's likely to respond to immunotherapy, and for that we need a lot of tissue. So these are the common actionable mutations in lung cancer that we know of today. And you can see that the pie is predominantly sliced by KRAS and none. So in around half of the patients, we don't have a driver that is actionable. But in the other half, you can see that there are patients with EGFR mutations, BRAF mutations, MET, and then there are much smaller slices of the pie. And what these molecular drivers tell us is that these tumours are most likely or very likely to respond to a targeted therapy. And you can see those different targeted therapies there. There's some EGFR TKIs here, BRAF TKIs, and these are ROS1 and ALK. We also use tyrosine kinase inhibitors for these tumours. And so if you find one of those, the treatment, if a patient has advanced disease, is to use a tyrosine kinase inhibitor. And those TKIs are very effective. And there are several trials now telling us that using the TKI up front is better than using chemotherapy. So that's why we look very hard to see if we can find one of these molecular drivers. But as you can see, most patients actually don't have one of these molecular drivers, and it's different actually across different ethnicities. If you lived in Southeast Asia, your probability of having one of these molecular drivers is actually quite a lot higher than if you live in Australia, for example, where the incidence of having an EGFR mutation is about 12% compared to Southeast Asia, where it's about 30%. And so in the majority of patients, we're not thinking about a tyrosine kinase inhibitor. We're thinking about either chemotherapy or immunotherapy. So what is immunotherapy? I wasn't sure how much basics to go into, but I thought I'd just quickly either rehash your memories on some basic immunotherapy. And I chose this. This is a very old paper now from Tony Rebas in 2012. But I think it's the most simplistic and easy to understand. So really there are several phases to the immune response. So the first is the priming phase, when dendritic cells present an antigen to a T cell. The T cell goes back into the lymph gland, it clonally expands, and then that clone of T cells can then target whatever it is that that antigen is directed against. And in cancer, we know that this occurs, but for some tumour types, the tumour is able to switch off that immune response. And so some of the ways things can be switched off are down here. You can see in the priming phase, this molecule CTLA4, pretty much within several hours of the antigen presentation, this molecule is upregulated, called CTLA4, and it is the brake. So as soon as that's upregulated, the immune system switches off. And in the effector phase, a similar thing happens to this protein, PD-L1. So PD-L1 becomes upregulated pretty quickly, and it binds to PD-1 on the immune cell, and it switches off. It's the brake for the immune system. And these are the two checkpoints that are commonly targeted in multiple cancers, where most of the data have arisen. So the CTLA4 antibody is called ipilimumab, and there are several different PD-1 and PD-L1 antibodies which basically take the brakes off this part of the pathway. So PD-L1 is a protein that's expressed in it's strongly expressed in around 30% of non-small cell lung cancer, and shown here is what we actually look at. This is immunohistochemistry for PD-L1. So this is a tumour that's 1% positive. This is a lung cancer. This is also a lung cancer. Now it's 50% positive. This is a melanoma, actually. This melanoma is negative. It's the same tumour after repeat biopsy was actually quite strongly positive. So we use PD-L1. We need histology to determine what therapy to use. And the other thing we've now come to recognise is PD-L1 is not the only molecule that's expressed. It's often co-expressed with multiple other checkpoints. And this is just some data from my own lab group showing that. So here's the tumour cells here staining with cytokeratin. This is PD-L1. You can see it's very nicely expressed in the tumour as well as in some of the immune cells that surround it. And then there are other cells that are lighting up. CD8 is very prominent in this tumour, and this other marker, IDO1, is also very prominent in this tumour, and we would call this a hot tumour. It's very likely to respond to immunotherapy, and it's probably likely to respond to combination immunotherapy, and we are now looking at inhibitors of both FOXP3, which is T regulatory cells, combining those with the inhibitors of IDO1 and PD-1 and PD-L1. So that's really where we're moving from just single agent immunotherapy to combinations where you're targeting multiple areas within a hot tumour. So what are the immunotherapies that are currently available? So in the first line setting, so we generally divide how we treat lung cancer into when you use the therapy in the first and the second, the third, and I'm now just talking about in the metastatic setting. So pembrolizumab is available in the first line setting if your tumour is PD-L1 greater than 50%, and that's based on a trial which showed that it is better to standard chemotherapy. In the second line, it's available if your PD-L1 is greater than 1%. Nivolumab is available in the second line setting, as is atezolizumab. So these are all PD-1 or PD-L1 inhibitors. Durvalumab, as I was saying before, from the Pacific trial, is available post-chemo radiotherapy. And that's across jurisdictions now that these drugs are available. But I think it's very poignant to point out that our treatment paradigms are changing rapidly. So this is the New England Journal of Medicine from last week. There were 3 publications on using immune checkpoint inhibitors in lung cancer, and probably 2 of these are likely to be practice changing. They haven't quite hit it yet, but one of them probably is practice changing, and that's this study, which I'll tell you a little bit more about. This is using pembrolizumab in addition to chemotherapy for non-small cell lung cancer. But some of these others are interesting, using immune checkpoint blockade in the neoadjuvant setting and showing a complete response rate in 45% of cases, and then combining nivolumab and ipilimumab, so PD-1 inhibition plus CTLA4 inhibition, and showing this to be better than chemotherapy. And so things are changing very rapidly, and our current paradigms are unlikely to be around for much longer. And so this is where I think we're at. I think this is how we probably should be approaching the management of lung cancer in the first-line setting. So this trial, the Keynote 189 trial, and I'll show you a little bit more about this, actually showed that using chemotherapy, so this is this study, chemotherapy plus immunotherapy is better than chemotherapy alone. We already had heard that this immunotherapy was better than standard chemotherapy if your tumour was more than 50% positive for that marker PD-L1. In this study, it didn't really matter what your PD-L1 level was. So you don't need to know PD-L1 status, you can just start chemoimmunotherapy, and we already know that this is probably better than chemotherapy alone. There are some caveats with that trial, but to date, it looks like this is something that's going to change practice. In the States, the combination of chemotherapy and immunotherapy has already been FDA approved based on a prior phase 2 study called Keynote 21G. And so it is available, and I'm pretty sure it will be rapidly adopted on the back of the Keynote 189 study. And then there are other studies also showing that combination chemoimmunotherapy is better. So this trial is called Empower 150, and it showed that chemotherapy plus bevacizumab, which is a VEGF inhibitor, is better than chemotherapy alone. This trial is using combination immune therapy and showing that this is better than chemotherapy alone. So we're using chemotherapy up front at the moment, but I don't think we'll be using it for much longer. So this is the trial that was published just last week. And just to show you, so the hazard ratio here again is quite strong. This is for overall survival. Hazard ratio is 0.49. You can see if you're treated with chemoimmunotherapy, you do a lot better than if you just receive standard chemotherapy, and all subgroups benefit. And so you can appreciate there that even the subgroups where PD-L1 positivity is not high also benefit from the combination approach. So where are we currently in the second line setting? So that's the first line setting. In the second line setting, nivolumab is the main drug that we use. We know that it is better than docetaxel, and we also know that another drug called atezolizumab is better than docetaxel based on randomised phase 3 data. This is a summary of the phase 3 trials that we have to date, which really points towards using immunotherapy, and nearly all of them are positive except for this second one, which was Checkmate 026. But again, this is about to change by using chemoimmunotherapy. So I think I made this slide at the end of last year, and already a couple of months later, it's about to be superseded. What about oncogene-driven tumours? So I told you that there was the other slices of the pie where you have EGFR and ALK and ROS1. Those tumours actually don't tend to respond so well to immunotherapy. So tyrosine kinase inhibitors remain the standard of care. And this study, which pooled the data from the phase 3 immunotherapy trials, clearly showed that if you have an EGFR mutation in this case and you receive immunotherapy, it is no better than using chemotherapy. So in this group of patients, we tend not to use immunotherapy until the very end. It's also important to recognise that when we're talking about response and treatment of lung cancer, the potential of patients that could the number of patients that could potentially respond to immunotherapy is quite high relative to other tumours, but if relative to the number of deaths, it's not so high. But it's also important to recognise that most patients actually don't benefit from immunotherapy. So chemotherapy was still going to be the backbone of what we did. But now with chemoimmunotherapy, we're not really sure where things are going to fit and how things are going to play out, because it really is a paradigm shift. Understanding the biology, I think, is critical, and I showed you those diagrams about the clonal heterogeneity previously. Just to bring this into focus, these are a group of patients who were treated on an immunotherapy trial, and then their tumours were sequenced by whole exome sequencing. In blue, a clone, so a clonal tumour. In red, you can see there are other subclones. So if you remember, there was a trunk and then several branches. So these tumours tend to have more branches. These tumours don't. And these patients had really prolonged, durable clinical benefit to immunotherapy. These patients didn't, telling you that the subclonal neoepitopes are the ones that don't respond. And we know also that giving chemotherapy changes the neoepitope repertoire such that you drive more subclonal events. So using immunotherapy upfront is probably going to be the way we utilise immunotherapy going forward. And this is the ultimate idea. I think we're here at the moment where we've got our first generation agents, we're getting to the second, and the idea is that we push the tail on the survival curve much further up to where we currently are, and that we bring this not just into from stage 4 disease, but also into earlier stage disease, and that is certainly where things are going. So in conclusion, the standard of care is rapidly changing in all settings. Immunotherapy is new, it's exciting, it should be considered in all non-small cell lung cancer patients at some point in time. It doesn't seem to work in patients with small cell lung cancer as it currently stands, although there are some ongoing studies that look interesting. But note that most patients don't respond to single agents, and so we need to be doing a lot better. I think chemoimmunotherapy is certainly the first step forward, but immunotherapy combinations and chemotherapy combinations is probably where we're heading. These are just some of the trials that are due to be read out shortly. Some of them have already read out. So just to show you how rapidly things are moving. And on that note, I'm going to end, and I found this, I thought this was quite funny. I want you to find a bold, innovative way to do everything exactly the same way it's been done for the last 25 years, and in lung cancer, it's more like 25 days. With that, I'll finish, and thank you.
Thank you, Tom. We might hold questions till the end of the session. That way we can perhaps extend the session if there's enough interest. So if you have questions, we'll just wait till all the speakers have had their presentations. So the next speaker is Associate Professor Eddie Lau. He's both a radiologist and nuclear medicine specialist with an interest in lung carcinoma. And he'll be telling us about FDG PET-CT in lung cancer. Thank you, Eddie.
Thank you, Sam. So for my presentation, you have to do some work because I'm going to give you some questions. And so make sure you have your apps ready, and probably in the second half, we'll go through about 6 questions and we can have some fun. So in my presentation, I'm going to cover, in the first 15 minutes, briefly cover the evidence for FDG PET-CT in lung cancer staging and assessment of pulmonary nodule, and then briefly outline some of the advantages of this technique in our current lung cancer practice. And then for the second half of the presentation, we'll go through some cases and illustrate some of the pitfalls and have some interaction. So I was fortunate to be involved with FDG PET early in my career when the evidence of PET was gathering at that time. And this is a typical case from those early days. A patient with, presented with a nodal mass in the axilla and not known to have any primary malignancy. And he went to the surgeon, obviously had an operation, had a nodal mass excised, and that would turn out to be metastatic carcinoma. And the next thing to do, they would be asking for the PET scan, and to look for staging and also find, what's the underlying primary site. And on the PET scan, you can see, keep pressing the wrong card, sorry. There's clear abnormality in the left upper lobe anteriorly. And I went back to look at external CT that was done in the very beginning. I'll be able to find that peripheral primary lung cancer that was not detected prospectively. So the typical cases like this on a daily basis, and the clear complementary roles of PET and CT, which led us to the PET-CT that we have today. So looking at the characterization of solitary pulmonary nodule, this is a case of a patient presented with limbic encephalitis, and often the neurology would say, oh, it could be paraneoplastic neck mixture, is not due to cancer. And on a CT, we found a left lower lobe nodule. And then we went on to have a PET CT and to see whether this is cancer or not. And the PET doesn't show any increased activity, so it's benign on PET criteria. And in those early days, we wanted pathological confirmation, which we did on CT-guided biopsy, and it's confirmed to be a benign hematoma. And in those early days in the 90s and early noughties, this is our local data from Melbourne, Peter Mac, and we had a very good sensitivity and specificity, just using the good old FDG PET on a single standalone platform. And then the accuracy improved on the PET CT platform with high sensitivity, even though specificity wasn't increased at that time. But I think with our familiarity with the PET CT platform and people being more aware of the CT features of benign and malignant lesion, I believe that we are able to make a more specific and diagnosis in most of the time these days, but certainly nowhere near 100%. In terms of nodal staging of lung cancer, this is probably the most quoted paper in PET, especially in the field of lung cancer, showing a vastly superior PET accuracy compared to the CT, which was a standard of care. And it's not just a few percentage more accurate, it's 10 to 20%. Is a big shift in terms of accuracy. And that really put clinical PET, FDG PET, and lung and use of it in lung cancer on the map. And this is a case initially thought to be T2N2 right lower lobe cancer, and with the PET CT showing a non-enlarged lymph node on the contralateral mediastinum, which is metabolically active, upstaging the patient to N3, which is what mostly happened when we do a PET scan, FDG PET scan for lung cancer. We're upstaging the patient in probably 30% of the time. And this is but in a minority of the cases, about 10% of the time, we are downstaging the patient. So as in this case, initially thought to have an N3 contralateral mediastinal nodal involvement because of a mildly enlarged lymph node in the aortopulmonary window, but the FDG PET was clearly negative. So we could also downstage a patient and potentially allow a patient to have curative treatment, which was not thought to be possible. In terms of distal metastatic staging, and that's even more impressive. This is a case from those early naughty days, presumed localized right lung cancer with a PET CT showing lytic destructive bony metastases in the cervical spine, which wouldn't have picked up on our standard CT chest and upper abdomen protocol in those days, and probably not going to be seen on your planar bone scan either due to the lytic nature and the cervical spine location. And Michael McManus, you'll hear from after me, and he's our clinician champion in FDG and in PET scan in general for lung cancer. And this is a study he led in those early naughty days. And we look at those patients who are thought to have just intrathoracic disease. And what's it? And when we do the FDG PET, and we realize this, even stage 1 patient had quite a significant percentage of distal metastatic disease that were not recognized. And in that cohort of patient, the change in staging really led to 35% of patients having a major clinical management change, really supporting the role of FDG PET in the clinical setting. And this is another example with a presumed localized thoracic metastatic lung cancer demonstrating a muscular metastasis in the left gluteal region, and that would never been picked up in a pre-PET CT era. You just can't see it. And the PET CT was found to be significantly more accurate than PET and CT done independently or separately. And it's this strong and compelling evidence in the early noughties and the 90s that really helped to put clinical PET CT in the forefront of oncology practice. And I think really allow us to ensure that we have reimbursement for this technique from various governments and insurance agencies and make it really available to our patients in these days. So what are the other advantages of FDG PET-CT in our current practice beyond its superior accuracy? It's really a unique text that gives you really the big picture. And I think that's particularly important in our current very busy multidisciplinary meeting setting. I'm sure we're trying to get through more cases, and really in having this picture really allow everyone in the MDM room, even those at the back of the room, to quickly comprehend what's the disease status and what's the disease extent, and allow the discussion of care management decision. And for the last few years, there's also increasing interest about performing FDG PET-CT early in the lung cancer patient journey rather than doing it right at the end. And I was involved with the Australian lung cancer guidelines, and we recently revised the guideline on the Wiki platform to make it more accessible. And one of the questions we were keen to look into is about the timing of doing PET-CT. Should it be done before biopsy when it's confirmed, or after biopsy before it's confirmed, or should it be done before biopsy? When we look into the literature, there's not a lot of high-level evidence, but it was clear that there's international consensus and agreement that there's a great potential for increasing patient care efficiency if we do early PET-CT, and without any major increase in cost, by triaging appropriate biopsy procedure and also guiding management plan. And how does that happen? As in PET-CT guided biopsy, this is an example showing that a bullseye biopsy approach is not always the best. I'm sure the radiologist was proud that he got into the middle of the lesion, but unfortunately, all it generated was necrotic tissue. And then we went on to do PET-CT. Maybe it was benign, or is it a necrotic tumor, as it was confirmed on the PET? And we showed that the active tumor, is actually in the periphery and lateral aspect of the mass, which we targeted subsequently based on this information, and we managed to get them as a representative tissue. And in our hands and also in other people's experiences, PET-CT guided biopsy is both feasible and very reliable. Not only does it allow us to biopsy the right area, it also allows us to direct our biopsy effort to the most stage-critical lesion. So this is the case I was presented with a solitary extrathoracic abnormality on the PET-CT with an active left adrenal gland. When we go back to look at the CT component of the PET-CT, there was not much of a mass in that left adrenal gland. It does look a bit fat and bulky, but nonetheless, we thought that was the one to chase, and that's the one we should biopsy first, because that would give us the most information about how to look after this patient, which we did. And I was fortunate enough to get below the lung base and managed to get core biopsy, and we confirmed metastatic adenocarcinoma, and we were able to do the mutation testing that Tom so dearly needed to treat his patient. So that was really improving the patient efficiency in terms of care. And not only just for lung lesion biopsy or distal metastatic biopsy, also in nodal staging biopsy, and it really provides a very good nodal map to our endoscopic colleague. And I know that for a fact because I used to get lots of phone calls from them and saying, we really need this PET scan before we do the biopsy. But then I asked them, have you confirmed it to be lung cancer? I said, well, we can't confirm it until we have the PET scan so we can biopsy the right lymph node and we know which to target. And it's clearly that it helped them a lot in the day-to-day endoscopic procedure, helped them to be efficient and targeting the right lesion and also the nodal lesion that matters. And it used to be more done by the endoscopic ultrasound route in the older days, in the early noughties, but with the advance in transbronchial technology and equipment, now I think they almost exclusively done the EBUS route. And it helped to guide radiotherapy planning. I'm sure that Michael will expand on that, but I did pinch these slides from him years ago, and he probably forgot about it, and it showed how we're able to define the primary tumor extent eloquently using PET-CT from the adjacent collapsed lung, which would be difficult if you just rely on CT alone. And I was involved with a study led by Michael that we look at the CT-based treatment volume compared with PET-CT treatment volume. We find that if we just rely on the CT alone, we would have missed 30% of the tumor, which is not a good news. And lastly, not just in staging and initial diagnosis, it's also very useful in restaging assessment of response in patients who are undergoing radical chemotherapy. And within another study led by Michael, that we find that more patients were able to have a complete response based on metabolic criteria compared to structural criteria on CT. And this more confident and accurate response assessment give us the potential to select the patient, the right patient with a truly localized residual disease to have salvage surgery. And we know that the response assessment is accurate on PET because it provides a prognostic certification that we want in an accurate response assessment test. So clearly there was survival benefit comparing the complete response cohort to the partial metabolic response, and that's also more superior to those who have no metabolic response with a highly significant p-value. So now we go to the interactive component, and I hope you get your apps ready and go into the event, which is this current session, and I was told by Matt that those choices and those questions would come up and you'll be able to make your decision, and we'll see how we go. Okay, so let's start with the first case. I'm going to show the images first because it wouldn't be fair to have a question without any clinical information or pictures. So this is a 45-year-old male, a smoker, presented with a cough. And we found an 8mm nodule in the right upper lobe on CT. Went on to have PET-CT with FDG showing mild FDG avidity, less intense in the mediastinum and liver. So my question for you is, what do you think about this nodule? Is it more likely to be benign, more likely to be malignant, 10 to 20% chance of being malignant? Not sure, recommend follow-up CT. Not sure, let's cut it out and biopsy it anyway. So I'll give you, oh, that was quick answer. And there can be more than one correct answer, okay? I'm just going to pick the one that I like best, which might not be the one that you agree, but so I think everyone's right. I think it's more likely to be benign, but that's not what I told my referring doctor. If I go back to my slides. So third one is my answer, and that's what I told my respiratory physician colleague. And the reason I told him that is just before I read this case, I came across this report from the South Korean group. They look at a cohort of patients very similar to the case that I was reading. Small lung nodule, little bit of FDG avidity, and in their series, they had a 19% chance of malignancy. So we know it's not 100% sensitive, FDG PET, there's a volume limitation. So that's what I told my referring physician, and he said 19% is, or 20% is too high for someone of that young age, 45-year-old smoking, and I think we need to have physiological confirmation, and we biopsy it, and it turned out to be a low-grade adenocarcinoma. FDG PET is particularly useful in those lung lesions which has a low to intermediate risk probability. I think we have to realize that it's not always cancer or not conclusion, but rather it's a way to help our clinician to manage the patient, to know whether it's safe to do an observation policy, a follow-up policy, or is it more appropriate to do an intervention and biopsy or resection approach. So now go to the second case. A patient, 50-year-old with known pulmonary histiocytosis X, so his lungs kind of abnormal and not very pretty. And he presented with bilateral lung masses. So they all look a bit irregular on the CT. There might be a bit of cavity in the right upper lobe lesion. And there are two masses in the left lung, upper lobe, and also apical segment, left lower lobe, and they seem to have central cavitation. And clearly, the left lesions are very metabolically active and seem to have a left hilar abnormality, and the right lesion is not that active. So regarding the lung masses in question, these are your choices. Right being benign, left being malignant, right or left is just not the same thing, or both can be malignant, or both can be active inflammatory lesion. Very good. You picked the answer I like most. I think that's to illustrate the non-specific nature of FDG PET, which is often the problem we face when we're reading, FDG PET CT, because it's not always specific for malignancy. But we can clearly tell, I think this is a concept of metabolic signature that we follow. The same pathology should have a similar intensity on your FDG PET. So we know the fact that the right is a lot less intense than the left lesion, then they're different pathology, And both, and all these lesions were biopsy under EBUS, and the left were lung cancer, metachronous lung cancer, and the right was aspergilloma in a pre-existing cavity from histiocytosis X. Third case, patient with a presumed left lower lobe lung cancer for staging PET CT, the good old staging PET CT we do all the time. And when patient presented, I often look at the external CT because it's very important to look at the temporal change in how the lesions are tracking. So there's a large left lower lobe mass involving the pleura. And then I read the PET CT after that, and I was surprised. It was only 4 weeks after we had the external CT that we look at. And then the mass is there, it's peripherally very active. And we have some left hilar abnormality. But then there's new hydropneumothorax, which was not there 4 weeks ago, and it's got increased pro-uptake on the FDG PET. So what's happening? So these are so what are the key findings? These are the answers I have. Left lower lobe primary lung cancer, left hilar nodal disease. Is it complication by empyema? Is it bronchoprofistula? Is it bronchoprofistula as well as pleural dissemination? It's too easy, isn't it? When you have the good test, it makes lives a lot easier. Yes, my favorite answer was also your favorite answer. Oh, sorry. So indeed was a complication, and it really showed me how lung cancer is really a bad disease. Over the many years, we still haven't improved the survival by a lot. And previous imaging is very helpful. I know FDG PET CT is a very good test, but I think time can often be a more powerful test in showing you what's happening with the patient. And 4 weeks can be a long time for bad cancer. And bronchoprofistula and pleural dissemination is certainly a complication of lung cancer. It's very rare. I know it's been written a lot, but in 20 years of practice, I've probably seen a handful of cases. So it's good that we don't see it as often as we should, because it's make it incurable. The fourth case is a post-treatment assessment case. A patient with right hilar lung cancer having radical chemoablation. And on the post-treatment PET CT, which is what we're concentrating on, the mass is smaller, it's less active, but we have new lung abnormality. We'll go back to look at the PET CT under the lung window setting, which we should when we're looking at lung pathology. And we see this area of opacity, ground glass opacity, so it's sort of a fuzzy opacity, but we can still see the blood vessel, and that's what we call ground glass. In the right middle posterior lung, seem to have a straight border. So what do you think about these new interval changes? Lung cancer responding? Do we have lymphangitis? Do we have pneumonia now? Do we have radiation-induced pneumonitis? Or can we blame the chemotherapy doctor for it? Yep, it is indeed a radiation pneumonitis. It's very classical once you know what you're looking for. And it's demonstrate typical features of a strict border. You ask the radiation oncologist, and where do you point your beam, and then they will exactly where the abnormality is being shown. And lymphangitis doesn't have this kind of pattern. It's more subpleural distribution, more diffuse, and chemotherapy-induced pneumonitis also doesn't have this regional, localized distribution. And FDG-positive pneumonitis might benefit from steroid. I think, is that true, Michael? Because it will prevent patient getting symptoms and probably prevent injury as well. We're coming to the end now. I think second last case is not quite a lung cancer, but it does show a thoracic abnormality, and that's why I have included it. It's a young man with metastatic melanoma. I just show you that Australia is the capital of melanoma, and we have 30-year-old man presented with metastatic melanoma with nodal disease involving the left pulmonary hilum. He went out to pneumonectomy, and after pneumonectomy, you have chemoradiation as well to make sure that all the tumor is gone. And this is sort of a surveillance, a follow-up to ensure there's no recurrence. And we see a hot spot in the left mediastinum. It's kind of hard to tell on the CT because of a post-op distortion. So what are we seeing here now? And we haven't got previous scan to compare. Are we having local recurrence? You always worry about local recurrence. Is it just physiologic cardiac uptake, or do we have some focal uptake that we see after radiation? We say, oh, I can't be sure. Maybe we just do another PET scan in a couple of months. Or maybe we should do a diagnostic CT to correlate. So I think it is an equivocal finding. Most people seem to think, maybe a follow-up PET CT would be helpful. And I couldn't decide. I need to choose two. And when you're the presenter, you can choose as many as you like. So when I look at it, actually, I got a phone call from the clinician. He said, should we just do a follow-up PET CT, or do you think we should do something else? And I look at it, I think it's probably focal myocardial uptake after radiation. It just sort of doesn't quite look right to be metastatic or local recurrence. But I wasn't comfortable without doing other tests, and I thought, rather than waiting 2 months, maybe we just do a diagnostic CT and see whether the uptake corresponds exactly to a part of myocardium. And we did the diagnostic CT, and that's shown on here, and then showing looking at where the hot spot is. It really corresponds to the location of the left atrial appendage. And when you look at the literature, it's actually very common to get focal myocardial uptake after radiation. 3/4 of the patients have it, and they can wax and wane, and sometimes you see it, and sometimes you don't. And so I think the time that when you have a diagnostic CT with anatomical correlation is helpful in some of these cases, and you might be able to solve the problem in a much shorter time frame than wait a few months, creating anxiety for the patient and the referring doctor. Last case, so we can't finish the case without immunotherapy. It's just not on. So we have to have a case of 54-year-old with a metastatic non-small cell lung cancer, and now listening to Tom, I know this is a second-line treatment. he's had chemoradiation before, and so it all makes sense to me. He presented to us late last year to Austin, Oliver Newton-John, and it's got moderate widespread metastatic disease, as you can see in the February scan. And then we started soon with nivolumab and had a very good response. Not quite complete, but a very good response, and just have a little bit of disease left on the September scan. And then early this year, he came back with shortness of breath. So we thought we'd better do a PET-CT, see what's happening. And it looked bad. And I got a phone call from one of the medical oncologist fellows. He said, can you tell me what's happening? He doesn't seem sick enough to have recurrence disease, but the PET scan looked bad. So I said, let me have a look. So when we look at the CT, and more critically, we can see some funny opacity. There's some ring-shaped opacity. There's some fuzzy consolidation, and there's some areas of ground glass opacity as well. And this is previous chemoradiation changes. And all these opacity have a variable amount of FDG avidity. So what are you going to tell your medical oncologist colleague? It's coming back. You're not working. Or is it hypersensitivity pneumonitis? My oncologist friend told me, this patient's a bit funny. He's been having some hot tub therapy with maybe he's getting sensitized to those chemicals that he's having, maybe. Pneumonia, is it lymphangitis? Or do we have immunotherapy-related pneumonitis? Oh, everyone's been listening. Tom, you should be proud. And I don't have to go through this first bit now because you're now expert on immunotherapy and what the checkpoints are. But pneumonitis is not that common. It's only in 5 to 10%, we see infrequently, and tend to happen months after treatment. So the time point is important. It doesn't happen straight away. And it has a typically described pattern on CT of the lungs, and which we're seeing in our case, got an organizing pneumonia as well as a ground glass opacity. So it's very important for us to understand the CT component of it and help you to make that call. So I think, and that's been covered as well, there are things that we see on the PET-CT after people with immunotherapy, and sometimes they're just nuisance, as in a sarcoidosis flare. They're just showing that they have a good response at activating the lymph nodes, but they're not really symptomatic. Unlike the other cases, the case of hypophysitis that Rod Hicks showed earlier today, but those patients with hypophysitis are usually symptomatic and have nausea and vomiting, so this is something you really have to recognize and alert your medical oncologist. Not that it's a metastatic disease, but it's some treatment-related problem. They might have to have a drug holiday, you might have to have steroid. So it's important information to pass on. So that's all the interactive cases. I just want to finish the very last case. It's a patient with a history of right upper lobe lung cancer, which has been treated, and now it's got a new left upper lobe lesion, thinking that might be a new lung cancer. How lucky or unlucky can you be? You beat up one and you get the other one coming as well. And a bit more story is his right upper lobe cancer was initially treated by chemoradiation, then he had a recurrence, and we had salvage resection, and then we get a wound infection as well. So when we do the FDG PET-CT, both the chest wall is hot and both the nodule are active as well. So do we have cancer coming back locally and then a new cancer as well? And rather than going to a quiz or doing biopsy, at that time we had access to another tracer called FLT. It's a thymidine analog tracer. It's a proliferative agent, and we thought that would be helpful in elucidating what FDG PET-CT couldn't. And we found that the new lung nodule is hyperproliferative, so malignant, while the chest wall abnormality is not proliferative at all, so it's consistent with ongoing wound infection or inflammation rather than local recurrence, so we don't have to worry about that. So the new lung nodule has stereotactic radiotherapy, and the patient carry on. So in conclusion, I think I hope I've shown to you that FDG PET-CT is really a key in the diagnosis of lung nodule and staging of lung cancer. And there are other benefits of FDG PET-CT as well: improve the lung cancer care efficiency, help us to do the right biopsy and treat patient appropriately. But the non-specific nature of FDG PET-CT does give us the headache. There's a problem and limitations that need to be recognized. And fortunately for us, PET is more than FDG, as I can show you on the last case, or the other things that we can do. And thank you for your attention.
Thank you, Eddie.
Yeah. Okay, now we'll go to the third presentation. It's Professor Michael McManus on the role of PET-CT in curative intent treatment of lung cancer with radiotherapy.
Thank you very much. Thank you very much. It's a great honor to be able to give this talk. Like Eddie, I was appointed to work at the Peter MacCallum Cancer Centre in the 1990s. I was appointed in 96, and the subject of my talk didn't exist then. We got our first PET scanner that year, and Rod Higgs was a visionary, and I was working in lung cancer, and so we had to work together to try and work out how you could use this new tool for treating patients with radiotherapy for lung cancer. So radiotherapy is the primary curative modality for people with unresectable non-small cell lung cancer. And when we got this new tool, we didn't really know what to do with it. This is how we did visually guided radiation therapy in the early 1900s. So these are patients who've got radium applicators, and they're holding up to their faces where they have skin cancers in various places. And so not only is each patient getting their own treatment, but they're also giving the person beside them the treatment as well. And everybody's irradiating the nurse, so this is probably not an ideal way to do treatment. So to do radiotherapy to kill a tumor, we need to target it accurately at the tumor, and we also would like to spare the normal tissues as much as possible. We need the most accurate available imaging, and we've become very reliant on FDG PET. So why are we using FDG PET for this purpose? Well, because for defining the target in radiation, PET is by far the most accurate imaging modality. And Eddie's already shown us why. But this talk is about radiotherapy planning, but it's really not distinguishable from staging and patient selection and target definition. They're all linked together, and we use the same studies to perform all of these purposes. So Eddie's already explained why we want to use PET, FDG PET for characterizing lung nodules. And this is important for us because we have to decide whether a lump or nodule in the chest has to be radiated to high dose, damaging the lung around it. Often primary tumors have got satellite nodules, and if they're FDG avid, then the evidence is that an FDG avid nodule, particularly in a patient with lung cancer, is very likely to be a tumor. So we want to include that in the radiation field. If the patient has got a lot of those and we can't radiate them, then the patient is likely to be a palliative candidate. This is just an example of a T1N0 lung cancer. If the patient had this lesion as a satellite nodule, then we definitely want to include that. So Eddie's already shown us that another reason for doing PET scan is to stage the mediastinum. The reason that most of our patients are treated with radical radiation treatment and not with surgery is that they have unresectable disease because of lymph node involvement. CT scanning is of some use in assessing the mediastinum, but several meta-analyses have shown that PET-CT is much more sensitive and specific, and CT is really not suitable for this purpose at all. There are many studies of FDG in systemic staging with non-small cell lung cancer. They all show the increased sensitivity and specificity, including several meta-analyses. This is a fairly typical example of a patient who is being considered for radiotherapy with a primary upper lobe tumor and a mediastinal lymph node, but unfortunately they also have bone metastases. So not suitable for radical radiotherapy with curative intent, although in the era of stereotactic ablative body radiotherapy, a person with a solitary distant metastasis may be curable with SABR. But the paradigm of locally advanced disease with a solitary metastasis being treated aggressively to all sites, it's not clear that that is a curative situation, but we tend to adopt that approach on an ad hoc basis. FDG PET's not very good for detecting brain metastases, but FLT PET may be good for detecting brain metastases. This is a patient from a trial of ours where we were looking at FLT PET. Patient was going to have radical radiotherapy, but unfortunately the FLT PET scan showed that they had distant metastases, subsequently confirmed by MRI scanning. So, as Eddie has explained, FDG PET is extremely useful for working out where the primary tumor is, and I apologize for using this slide again. If this patient has got a collapsed lower lobe and they have potentially curable disease, but we don't know where the edge of the tumor is on the CT scan, if you do a PET scan, you can see pretty clearly where the edge of the tumor is. And so that helps us to not geographically miss and also not to treat too much long. So these are more examples. This is a patient with a locally advanced tumor. On the CT scan, it appeared to be contiguous to the bone, but it wasn't clear to what extent the bone was being invaded. And we weren't even aware that there was any risk to the spinal cord on the CT. But when we look at the PET CT, we can see that this is a very extensive tumor permeating through the bone and contiguous with the spinal cord. So that's very useful information when you're planning radical chemoradiation for a patient. Another patient who has possibly got a radiation-induced cancer, previous history of breast cancer with a breast prosthesis, got a tumor underneath the breast prosthesis. Not very easy to see what the extent of the local disease is on the CT scan, but PET CT you can see that it's somewhat more extensive than you would otherwise suspect. And another finding that wasn't suspected was that there was contralateral hyaluronephritenopathy. So in this situation, the PET scan was extremely helpful in deciding whether the patient was suitable for radical treatment and defining the target volume. So this is really discussed selecting patients for radiotherapy on the basis of their anatomical disease extent. So what effect does PET CT have on patient selection? Well, the primary effect is to exclude people who cannot be cured. So when I first came to Peter Mac in the 90s, these were the kinds of results we were getting for radical radiotherapy. In fact, the bottom curve is the curve for people with radiation treatment for lung cancer. As a single modality. This curve is for surgery. This curve is for patients who had post-op radiation. And this is, and you can see that the patients who got radiation alone before the chemotherapy era had really terrible survival, with 7% 5-year survival approximately. So this is the setting in which we designed our first PET trial. And we enrolled 153 radical radiation therapy candidates with stage 1 to 3B non-small cell lung cancer, all of whom were considered to be candidates for radical treatment, radical curative intent radiotherapy on the basis of their pre-PET imaging. Then they had a PET scan, and that really changed things. Only 70% of them were suitable for radical radiotherapy after the PET scan, primarily because of locally advanced disease or primarily because of distant metastases in 20% of cases, or extensive nodal disease in 10% of cases. So the 70% went on to have radical treatment, including 5 who had surgery because they were downstaged by the PET scan. And so, well, we were very brave making treatment decisions based on a new imaging modality without being able to biopsy everything. So were these sensible decisions or not? Well, when you look at the survival, these were very sensible decisions, because the patients who had no radical treatment based on the PET scan findings had terrible survival, and the patients who had radical treatments had excellent survival compared to historical series. So already, without actually doing anything different except adding platinum-based chemotherapy, the survival was way, way better than what you saw in those previous curves. And well, is it clear that these PET-detected metastases are real? Well, if you've got more than one of them, then your survival is absolutely appalling. But if you've got one PET-detected metastasis, well, you still have pretty bad survival, but you might do better. And that's quite significant in the era of SABRE, where some of these patients could potentially be cured. So if you do PET scanning and use that for selecting patients and radiotherapy planning, does that lead to better outcomes? Well, It seems to, based on our own centre's data, comparing two identical series of patients, or as identical as we could make them from prospective trials, one in the PET era, one just before that era, with no other changes in treatment. So PET patients did way better. So it wasn't just us. There was another group that tried to do a similar study, and this was a Polish group who published in 2010 100 patients who had PET for selecting patients in radical radiotherapy, and they found that 25% of them were only suitable for palliative treatment afterwards. So technology advanced, and then we got our PET-CT scanner, and we repeated the same kind of study, but with a much more rigorous planning study associated. We wanted to see how much the target volumes changed with PET. So we decided to recruit 50 patients for the PET planning study. But in order to do that, we had to recruit a lot more patients who had a planning PET scan, because a lot of them would be found to have incurable disease on the PET scan. So we managed to get our 50 patients, but in order to get 50 patients who were suitable for radical treatment, we had to recruit 76 patients. So 26 patients were found to be unsuitable on the basis of PET-CT, an even bigger number than before, probably because PET-CT is better than PET scanning, standalone PET for detecting distant disease. 17% of patients had extensive metastatic disease, and 13 also had nodes that made their disease too extensive for radical treatment. Yeah. So, okay. So in that study, the patients again had even better. This is the survival for all patients, regardless of whether they got a radical or a palliative treatment, and that's significantly better than our previous study. And when you look at patients who had radical treatment compared to palliative treatment, a very, very large difference. So we were appropriately selecting people for palliation based on PET scanning. And we then got astonishingly good survival results for our stage 3 patients. So the stage 3A curve is the green curve. So that is just not far short of 40%, a little bit over 30% 4-year survival for stage 3A lung cancer, which is exceptionally good. This brings us to the effect of PET on target volume. So the patient has managed to get through the grim reaper of PET and has got disease that we think that we can treat with a high dose of radiation. So in order to do that practically, we need to define the gross tumor volume, and then using that, we expand that into a clinical target volume, which includes macroscopic disease extension as best we can estimate it. If there's movement, we do an internal target volume, and we want to treat all of that to a particular dose, and that's called the planning target volume. But inadvertently, we treat some extra tissue to a full dose, called the treated volume, and we also treat some tissue to a lower dose, which is the irradiated volume. But everything hinges on getting this right. So if the GTV is incorrect, you miss some of the tumor, then the patient will die and your treatment will be futile. Or if you make the GTV too big, then you can kill the patient by giving too much radiation to too much normal tissue. So in the early days, we had standalone PET, and we had CT scans, and we tried to fuse them together by getting the patient into the right position with fiducial markers and lining everything up. And it was pretty crude, but it worked. It worked. And so when we looked at the effect of that on the volumes that we treated, we found that, well, the coverage of the target volume was infinitely better if we adopted this approach. But then when PET-CT became available, this became completely outdated. So we didn't have to do that fusion anymore. We just got it all in the same machine. But then we realized that the PET scanner was now part of the radiotherapy quality control system. So the PET was really part of radiotherapy. So the PET suite had to be equipped with positioning lasers. We had to have the patients immobilized in the exactly same position as they were going to have their treatment. Flat couch tops, radiation therapists in the PET suite, getting the patients positioned so that when the patient is positioned on the LINAC, they're in exactly the same position. So we worked on that, and I'll show you the results of that slightly later. But in the meantime, we got involved with the International Atomic Energy Authority, and we did a review for the the IAEA did a review of PET in cancer, radiotherapy planning across all cancers, and made some sort of general recommendations about how PET could be incorporated into the planning of cancers generally. Over the years, a large number of studies of different types produced results on radiotherapy planning in lung cancer particularly. And so when taking account of all of this information, the IAEA convened some more meetings to try and synthesize this information into practically useful information. And so another paper was published in 2015 with Tom Connert and Jerry Hanna as the senior authors, with the intention of giving practical advice to how you should use PET for radiotherapy planning, and practical advice on how to do contouring. For example, this is a case with some atelectasis and the FDG avid tumor and an area of less FDG avidity around the tumor. So that area of less avidity is considered to be due to movement. And so if you want to cover the tumor adequately, you want to make sure that that movement is covered by your contour. So here's the contour covering the tumor plus the movement. And that's the suggested way of contouring this particular case. And this is another case where there's some air around the tumor, but if you look at the PET scan, this air is filled in, so the tumor is moving, and therefore the FDG uptake in this area is not an artifact. It's due to the fact that the tumor is spending some time in that area, which is otherwise air. So we need to include that in the contour as well. So the IAEA made some recommendations about how to time the PET scan, how to position the patient, how you window the contouring system, and advice on whether or not you should use automated techniques for contouring. Generally, automated contouring can be helpful, but it's only for assisting. You shouldn't contour based on an algorithm. So the IAEA now is running a study trying to teach these lessons to emerging countries which have got PET scanners but haven't yet worked out how to use them for radiotherapy planning. And that incorporates a clinical trial looking at outcomes before and after PET scanning was incorporated into treatment planning. So the study I told you about earlier, in which we wanted to get 50 patients, when we look at the 50 patients, we have this kind of study design. The patients who were radical candidates, they had a planning PET scan. PET-CT, if that showed extensive disease, then they were off study. So if it looks like it was radically treatable, the patient went down this pathway and treatment was given. And we also did a sub-study to see how reproducible visual contouring was. It was published in the Red Journal. So we had 6 observers and 6 tumors. And if you follow a rigorous contouring protocol, you can actually get very reproducible results for contouring. But if you just contour ad hoc without a protocol, then it's all over the place. So if you're using PET-CT for contouring, it needs to be done in a scientific way. So anyway, as Eddie has alluded to in this study, we found that without PET scanning, 37% of patients would have had a grade 1 geographic miss, that is, that they would have FDG of a tumor outside of the planning target volume. And a similar number of patients would have had a grade 2 geographic miss in which tumor was present within the PTV, but it was underdosed because it was too near the edge of it. And on average, no more normal tissues were irradiated to make this possible. So in that study, we did a planning PET-CT scan, and the patients had to be in the right position, and we figured that the PET scan shouldn't be too old. And a lot of the patients had already had a staging PET scan, not in the right position, so we were able to do a second PET scan in those patients. But then that gave us the chance to see how fast the tumors were growing without treatment in between. So we had 28 patients who had undergone a staging PET scan before the planning scan, and the average interval between the planning scan and the diagnostic previous scan was 24 days. And we found that there was disease progression in 39% of patients during that interval. And the probability that patients would be upstaged within 24 days was 32%. And that in 29% of the cases, the patients were changed from radical to palliative on their second PET scan. primarily. And we also found that the doubling time of the FDG avid tumor in these predominantly advanced cases was 66 days, which is a pretty short doubling time. And this is just an example of the patient from that study. So the staging PET scan above shows quite extensive disease, but the PET scan for radiotherapy planning 22 days later showed liver metastasis, supraclavicular nodal metastasis, and a lot more extensive disease in the chest. And well, these are just shadows on a scan. Do they make any difference? Well, if you have your radiotherapy declined as a result of progression between two PET scans, you have survival like this. Whereas if you have two PET scans and on the basis of the second PET scan you proceed to radical radiotherapy, your survival is pretty good. So this certainly appears to be a real finding. There are a lot of complexities involved in this area, which I won't go into, but just to flag them as being important. One is the effective movement, and 4D PET-CT is being explored for radiotherapy planning. And this is, this is the top images are of a 3D PET-CT, of 3D CT and PET-CT of a patient with a lung cancer that appears not to be very avid, but does seem to be moving. You can, but if you look at the 4D PET-CT, you can see this tumor is moving over. The 4D CT scan, you can see the tumor is kind of moving over a sausage-shaped area, and when you do the proper attenuation and correction because of the 4D PET-CT, you can see this actually is an avid tumor, and you can gate and bin the slices, and you can get a clear picture of the tumor in one particular point of the respiratory cycle. So that can be very useful for gated therapies. Not a big advantage if you're not giving gated therapy though, but very helpful for diagnosis, particularly in tumors that are low avidity, close to the diaphragm, close to the liver. So we're doing far better now with radiotherapy for lung cancer than we used to do, particularly for stage 3 patients, because we're giving concurrent chemotherapy. We're doing PET scanning for selecting them. We're doing PET scanning for planning the radiotherapy. And now we're doing even better because we're giving durvalumab to people who respond afterwards. So results for stage 3 lung cancer are improving all the time. Local disease relapse is a very common problem. So how do we fix that? One where the people thought is kind of a no-brainer. Let's just give more radiation and then we can cure more cancers. But unfortunately, it's not that simple. So the RTOG 0617 study randomized patients between 60 gray and more than 74 gray. And unfortunately, the mortality was higher in the people who got the higher dose of radiation. So that's why doses of around 60 gray are standard at the moment. But we can maybe do dose escalation in a smarter way. We just treat some of the tumor. And one way of doing that is being exposed by Josie Belderbos and Dr. Reicher in randomized phase 2 study in which patients get a boost to just the FDG avid areas of the tumor at baseline. And another way of giving more radiation is to do response-adapted treatment. So tumors get smaller during treatment sometimes, and why not give more dose to the areas of the tumor that are responding more slowly? And there's some evidence that PET is a better way of assessing response than CT. We published this back in 2003, and Eddie showed us some of the curves showing that people who got complete responses did a lot better than people who didn't, and people who had progressive disease had terrible survival. So this is how we look at the progress of a tumor during radiotherapy at the moment. This is called a cone beam CT, and the purple. This is the baseline and the treatment on the on-treatment scan overlaid. The purple is the baseline, and the green is the on-treatment scan. And you can see that the tumor has shrunk. Maybe you could shrink the treatment and cover that. But often you can't see the tumor on the CT scan. You have to use the PET scan. So why not use the PET scan for modifying treatment? One caveat is that tumors that shrink fast don't necessarily respond the best in terms of overall survival. So this study just looked at regression on CT scans, and it found actually the tumors that regressed the fastest had the worst prognosis. So a slow and steady response is better than a really fast one, perhaps. So this has led to the idea of adaptive radiotherapy. So we do that some of the time. When a patient has collapse, we do some radiation treatment, the lung expands again, and now the tumor is in a different position, and the nodal disease is in a different position. So a replanning PET-CT scan is very useful for targeting this. But people are going one step further and saying, well, why not give extra treatment to that area? And so there's a clinical trial in the US led by Spring Kong using PET response adapted dose escalation. So in the couple of minutes left, I'll just mention a couple of things that may be of interest in the future. FDG PET is by far the best tracer that we've got. It may not be the only useful tracer. Changes in tumor oxygenation may be of prognostic significance. And there's been a lot of work done with F18 misonidazole, and a better agent is FASA. And we did some studies with that in our center and showed that about 60% of the time we could image hypoxia in lung cancers, and that if you treat patients, that might go away. So this patient had chemoradiotherapy and gefitinib, and their hypoxia went away. So we don't really know what the prognostic significance of this. Numbers are too small at present, but it's an interesting thing to look at. Hypoxia makes tumors radioresistant, and therefore it may be possible to identify patients who could respond to hypoxia targeting agents. FLT is a very useful way to look at tumor proliferation, and we've done a study of FLT during radiotherapy. So this is a patient who had an FLT positive tumor in the lower lobe and in the subcoronal node. After 20 gray, the tumor was responding, and all the bone marrow in the chest had gone away. And at the end of treatment, the tumor had pretty much gone, but so had all the bone marrow in the ribs and the spine. So there's a good illustration of how damaging to the bone marrow even small doses of radiation can be. And this was clinically useful in one case in that study. This patient started radiotherapy and had an FLT positive tumor with a lot of necrosis. After 18 gray, the patient got SVC obstruction. The tumor was progressing. It was more proliferative. And in radiotherapy, if you've got a tumor that's proliferating too fast, the only way you can counter that is to give more treatment more rapidly. So we gave twice daily treatment to the patient, and they got a response, but they died soon after. This was just a very bad tumor. So we can image more than the tumor during radiotherapy. We can also image changes in lung function. So this is part of a GALI-PET study using PET tracers of ventilation and perfusion. And one of the interesting things about that study was just how early changes in lung ventilation and perfusion occurred. And there appeared to be a linear correlation between radiation dose and perfusion. And this is a patient who, from just last week, 2 weeks ago, had to stop his radiotherapy after 32 gray, couldn't swallow. And you can see why. His esophagus is extremely hot on the PET scan, consistent with radiation-induced esophagitis. So in conclusion, I would like to recommend that FDG PET should be used for radiotherapy planning for non-small cell lung cancer. So far, the evidence is in favor of using a visual method for target volume delineation. PET scanning that's used for radiotherapy planning should be acquired in the radiotherapy position with full radiotherapy positioning. The PET scan that you use for radiotherapy planning should be recent, within a couple of weeks. FDG is the evidence-based tracer to use. Other pharmaceuticals are experimental. Adaptive radiotherapy using PET response is also experimental. And imaging of normal tissues and toxicity with PET is at an early stage, but could potentially be useful in the future. So thank you for your attention.
Thank you, Michael. If we could have the speakers at the front, we'll spend a few minutes just to take some questions. Thank you. I had one question for Tom, actually. With immunotherapy, on occasion, we do see patients that have a prolonged remission. And my question is, how do you approach surveillance in these patients? Because the feeling is that they're going to relapse at some point in time. We don't know exactly when. So how do you manage that?
Yeah, it is something that thankfully we're actually seeing a little bit of more recently. I think the approach is that we know that the median progression-free survival, even in people who have very good responses, is still capped. So yes, the number of patients who have effectively cure, so 5 years down the track and no disease, is still small. We're still sitting at about 5 to 10% of patients. So at some point, those patients, even with a complete response, are likely to relapse. And so what I tend to do, and there's no rules here because in the trials, patients had ongoing scans every 6 weeks. I tend to stop doing 6 weekly sort of scans and switch to 3 monthly scans. And provided the patient's well in between, I don't see any reason to do anything more aggressively. And the other thing to say is that we now know that stopping immunotherapy at 1 year is not favoured. There was a trial that did that, and those patients that stopped actually did worse than those patients who kept going. So we do tend to continue. And when we get to 2 years, and I'm at that stage with many patients now, if patients don't have toxicities from their treatment, they're very scared to stop. So we continue, and we continue having to survey as well. So there's no rules and no answers. Yeah.
I think of interest to this audience is your preferred modality for follow-up.
That was a loaded question. I find PET imaging for lung cancer, particularly patients having immunotherapy, is way better than CT. Often because nodal disease is very difficult to delineate, and seeing a complete response on PET gives us a lot more information than seeing residual sort of masses on a CT and you're not really sure what they are. So I find PET scans to be a fantastic way of monitoring. But I do say that with a caveat that that's not actually what was done in the trials. All of the studies use CT. So that's how response was defined.
Thank you, Tom.
Monica, do you have a question?
Yeah, and maybe a bit of a mundane question, but all these new immunotherapy agents, can patients access them or do they have to be on a trial?
No, so in the second line setting, patients can access them. They're on the PBS, our PBS. In the first line setting, there are access schemes for, so as I was saying, PD-L1 greater than 50%. So you can access now this drug pembrolizumab through that access scheme. Your oncologist just needs to go to the company. And for durvalumab, after chemoradiation, there is also an access scheme. So pretty much for all of the current indications, except for chemoimmunotherapy, which, as I said, was released last week, we can access the immunotherapy. As in the US, they can access chemoimmunotherapy because it was pre-approved on a prior trial.
Thanks.
That's right.
Just a logistic question about the PET-CT radiotherapy planning. Does that mean you actually have your own scanner with a flat table and the lasers, or is that the same PET scanner that they have as part of the regular department? They just have one that you use for radiotherapy planning?
We're in the fortunate position to have multiple PET scanners at our centre, and one of them is dedicated for radiotherapy planning.
I'm envious.
I have one very quick question for Dr. Lau, and that is in patients who have metastatic disease from different clones, would you expect different levels of intensity or just different SUV levels?
I think that's uncommon at initial presentation. I think when they're treated, and especially with target therapy, you can have different metabolic signature because some are switch off and some are not switch off. So I think initial staging is not a phenomenon, but I think if they've been previously treated or recurrently treated, I think that become more problematic. Tom, want to make a comment?
We certainly see mixed responses, and presumably that is various subclones behaving differently. With immunotherapy, it's actually a lot more confusing what to do about that, and a lot of us will continue, provided the patient as well. And in fact, the clinical picture means a lot more than the imaging does in that setting.
Okay. Well, thank you all very much. I have two quick announcements here. The gala dinner is tonight, and your delegate badge is your ticket for entry. And you should have a little icon at the bottom, lower right corner. And if you cannot attend, please inform the staff. Then there's afternoon tea in the exhibition hall, and you can purchase coffee at the barista stations. Thank you all very much.